Hi, welcome to Thursday afternoon. I'm Michelle Peterson. I'm the Association Director for CCCMHA. And I am am I loud enough? Am I loud enough? I'm very excited actually to present this panel. One of the things we've been talking a lot about is in light of the funding changes for services for children, how do we go about changing the service models to provide the best care for kids in light of those funding issues. So we've invited Leslie Preston, the clinical director for La Clínica de la Raza in Oakland. We have Ken Berrick, the founder and CEO of Seneca Family Center Agencies. Family Agencies, I'm sorry, Ken. And then also we've invited Ron Powell from Desert Mountain SELPA to go ahead and talk about the successes that they've been having in their areas and looking at how those integrated models can work together. So with that, I think, Ron, are you up first?
All right, well, good afternoon. And knowing the time of the day and how deadly dangerous it is to try to keep y'all awake this late in the day and keep you here. So I'm going to get mine out of the way because then I don't care what happens with Ken and Leslie. They're kind of on their own. All right, so my name is Ron Powell. I'm the administrator of the Desert Mountain Special Education Local Plan Area, or SELPA. That's a consortium of 15 school districts in San Bernardino County. And we have 11 LEA charter schools that are also part of our consortium, and they're located down in San Diego. We actually have two SELPAs that are part of our infrastructure. We cover 20,627 square miles. We're larger than 11 New England states, and we're one of the most rural areas in all of California. And for that reason, about 20 years ago, we started providing mental health services on our own because of the lack of contracted services within our communities and the fact that so many of our parents were so remote that they couldn't travel to clinic for services, and we still had it on their IEPs, and we needed to provide those services or otherwise we would be in big legal trouble. And so our superintendents asked us to start that process. We started with two, and over the course of time, we were funding that totally out of education dollars, and about 10 years ago or so, our San Bernardino County Department of Behavioral Health put an RFP out into the community to provide school-based EPS-DT services. And when that happened, our superintendent said, you know, it would really be nice if we had a supplemental level of funding to be able to offset the education dollars that are going in to mental health services. And so we applied for it, and we got the contract. And so now we are a community-based mental health clinic under the Department of Behavioral Health, operating in concert with education entities. And over the course of the last 10 years, we've now grown to be the largest mental health provider for adolescents and youth in San Bernardino County. We provide services to over 6,000 students a year, about 3,000 active on a caseload at any one time. We start at birth, we go all the way through age 21, and I'll build in some of the description of some of our programs as we move through. You know, when we started this work, I can tell you that even though, you know, we are the largest mental health provider right now, and I have maybe 150 clinicians that are doing this work, we are barely scratching the surface. And I hear this kind of dialogue that's going on between agencies over the issue of who has responsibility in which areas of our county versus other areas. And I'm here today to tell you that we don't need to arm wrestle over kids. It's not like we're stealing them one from each other. There are plenty out there. And in fact, we don't need to truncate the level of services that are being provided. We actually need to add to that. And what our panel is here today to discuss is some ideas about how you might do that, about being able to establish collaborative partnerships so that we can provide mental health services to all those children who need them, And I'm going to lay the framework for what the need is, and Ken's going to follow up with a model that we are currently implementing, and Ken is implementing in Northern California, and he's taken it one step further because he's a non-public agency. He's not within schools. And that partnership that is existing in order to allow that to happen is something that is quite extraordinary. And then Leslie's going to take it another step further and give us another idea of how to fund these programs that are outside of the common methods of funding, which is schools and EPSDT, and then we're talking about federally qualified health HC, FQHC. And so Leslie will tell all about that. So then at the end, we're going to wrap it up and hopefully have the starting point for some good conversation and answering questions. So that's kind of the layout for how we're going to do this. And so let me just start. You know, when we started out, the big question was, what actually is the need? And as we began to look at the research, now we know that now more than 1 in 5 children have been identified with significant mental health disorders that adversely impact both their quality of life as well as their performance in schools. And among children of poverty, that rate is higher yet. So about 30% among children of poverty. Now, they say that one of the most deadly things you can do when you're doing a presentation is throw statistics out there. And so I've just given you 2 slides of statistics. Now, if that doesn't put you to sleep, I don't know what will. But for those of you that have really strong working memories, let me help you out. See, out of every 100 kids, the 20% that have significant mental health problems, you know, 20% of, you got it, okay? So you got 20 out of every 100, but among children in poverty, that's 30 out of every 100, right? And half of California's student population are children of poverty. 48% are on free and reduced lunch. You add those together, you have 1/4 of all the students that are attending public schools today have a significant mental health problem. You see what I said about we don't need to arm wrestle over kids? And the problem is that when you take a look at that, we are barely scratching the surface. Only 1 of those kids will ever be identified as emotionally disturbed and qualifying for special education. 25 out of 100 have a significant mental health problem. Only 1 will have an IEP. Why is that? Well, it is because most children that have significant mental health disorders don't also have a comorbid educational deficiency. And special education is unique in that they have to not only have a mental health disorder, but they also have to have an adverse impact on their educational performance. And to put those 2 things together dramatically reduces the number of kids who actually get the service. And I would like to say as well, that Margaret Mead is quoted as saying that if a fish were an anthropologist, the last thing that it would discover would be water. And so here you have a population of children that are embedded in an educational milieu. Do you think that educators uniquely are looking for mental health problems? No. Why? Because our number 1 concern winds up being their educational progress. And so these kids wind up falling through the cracks. So how did we get to where we are? It's not like though suddenly we have this influx of kids that came from that family and that's really messed up our whole percentage of students with significant mental health disorders, because you actually can recognize these problems coming very early on. In fact, research shows that 10 to 15% of our preschool population have significant, moderate, chronic behavior problems that are identifiable in early preschool age. And why is that a problem? It's because if they are acting out, they're more often rejected by peers, they receive fewer positive comments from the teachers, they do poorly in preschool, and as a result, they do poorly in kindergarten. And yet, if you talk to faculty of education programs that are preparing our early educators, they will say that our graduates are the least prepared to deal with these significant behavior problems. And so what does the treatment become? Would it surprise you at all to know that expulsion among preschoolers is 3 times that than among kindergarten through 12th graders? Expulsion becomes the treatment because they don't know any other way of doing it. And those kids who wind up having those behavior problems at age 3 and 4, that winds up being very persistent. Research shows there's a 50-50 chance that that behavior problem will continue on into adolescence. Because the correlation between early appearing significant behavior problems and later appearing behavior problems is actually higher than that for IQ. And we generally consider IQ to be a very stable kind of attribute. Well, so is behavior problems. It's a very stable attribute. Early appearing behavior problems is highly correlated with gang activity and juvenile problems later on, and we know now from the research to be true that if we don't catch them early and they reach the age of 9, then buckle your seatbelt and ride it out, because the chances of ever doing anything meaningful to change the life course of that individual winds up being lost. Now, years ago, we recognized the fact that we weren't catching kids early enough. We were providing school-based mental health services. We had a lot of kids at the junior high and the high school level. We were drilling down into the elementary level, and our folks were coming back and they were saying, we're still not catching them early enough. And we started with a 0 to 5 program. And when we did that, we put out a call to all the community providers, and we asked them to come and meet with us, because we just wanted to do the assessment and then refer them over to community-based agencies to do the treatment. And we had a room that was very much like this, and it was full of providers. And we asked the question, how many of you have been trained to do early mental health with a 0 to 5 population? And a few hands went up. And we said, how many of you have capacity to serve more? If we do the assessment and we make the referral, who can take them? And I'll never forget the kind woman, such a dear lady, from Catholic Family Services. She stood up and proudly said, we can take 3. We were anticipating assessing 500 to 600 children a year, and we had absolutely no capacity for service within our communities. So as a result, we started doing that business. And today we run a clinic for 0 to 5-year-olds. About 800 children come through that clinic every year. We're providing evidence-based practices to be able to address that. Why? Because we know that if we don't catch them early, that their life course is going to be significantly more poor than if we had do something about it. And in fact, those kids who reach adolescence, over half of them wind up abusing alcohol. They're more likely to abuse illegal drugs, marijuana, be involved with tobacco. They're more likely to drop out of school. 50% of them will drop out. And what happens when they drop out? Well, within 2 years of leaving school, 58% of them have already been arrested. 42% are on probation or parole. See, the fact of the matter is that these kids are embedded within an educational milieu, and anybody, if there is anybody, who has the most contact with this population of children, it's the educators. They're the ones who should be able to be trained to identify these problems early on and to make proper referrals. And yet the fact of the matter is that educators are as blind to these problems as anybody else. And I can tell you that just like at the preschool age, increasingly what we see is the treatment of choice winds up being suspension and expulsion. Just because you put the child back out into the community doesn't mean that you've done anything to address the mental health disorder. Less than 10% of all those children with significant mental health disorders, that 25 out of 100, less than 10%, that's less than what, 3, wind up ever receiving mental health treatment for that disorder. And the research also shows that the first day of treatment is on an average 9 years after the behavior first appeared. Go back to what we said was the critical age, age 9. If they don't appear with those kinds of problems until school age, that's the first time they're identified. 9 years later, when they first get treatment, they've already passed that magical age of 9. And the difficulty that we're facing is much more significant at that point. There has got to be a better way if we're going to do something with this population. Before I drove down here today, I had a meeting. We went through 3 suicides from one school in the final months of the academic year, between April and June. Now, any of you that have been through a contagion know that about 3 weeks after the first suicide, that's when you start to get the activity, and we mobilized our teams. We were on the campus every day. We were identifying every child who was at risk. We had a number of hospitalizations in the aftermath of that. We had trained a crisis team on the site, and they were very much in tune with that. And we made it through the end of the year without another suicide. But then the kids went away for summer. And when they came back, guess what happens? It like stirs the nest again, because kids are once again engaged with each other within the social milieu, and we start with that whole contagion business all over again. And right before I drove down here, I was meeting because a child walked away. He was on watch on the school site. Multiple attempts before, and he managed to separate himself from the group, tie his sleeve of his coat around his neck that was sufficiently tight that he passed out. That fortunately they found him before, he was a completer, and he's hospitalized now. And you know what we're doing? He was not a special education child. We're doing a simultaneous assessment for special education as well as what they're doing at Loma Linda Behavioral Medicine Center. And when he is released from that hospitalization, we're going to place him in a residential treatment setting because he needs that intensive level of support in order to get him through this period of time. Now, who all is doing that? It's the people that are engaged with the child at the time, at the moment, that are trying to lay eyes on him. And what that means is that we have to work together in a collaborative way with all of the partners coming to the table if we're going to do the best that we can do for these children. Suicide is the fourth leading cause of death among young adults, and yet I can tell you that very few teachers actually even know the signs. So, where do we go from there? What's our next step? Because the fact of the matter is that if we don't do anything, or whether we do something, school is the de facto mental health provider. And it looks like this. From the Indianapolis Star, you can see that the educator, it says Indianapolis Public Schools on his vest, is holding the child out the window of the alternative school, and he says, we can't afford to save this one, but don't worry, someone will catch him. And down below you have gangs, the judicial system, and the welfare system. Kicking the can down the road and expecting somebody else to handle the problem isn't the answer. And neither is it the answer for one agency to accept the responsibility for doing this work. This is a collaborative effort, and if we value children, we need to set aside whatever barriers keep us from working together in order to do this work. This isn't going to get done in any other way. There are evidence-based practices that are out there. We know what works. The research is very clear about the treatment modalities that actually are useful with this population. So it isn't a question of what to do, it's a question of will, of whether or not we can work together to cobble structures and frameworks that are sufficient to be able to support the mental health services that are needed for this population. So, there is a framework, fortunately, that is now nationwide. It's in well over 10,000 schools. It started with positive behavior interventions and supports, but it is now expanded. It is embedded already in the Individuals with Disabilities Education Act, IDEA, which governs all of special education. It is already embedded in the new reauthorization of the ESEA, which is the the Elementary Secondary Education Act, which is the part that funds children in poverty. And that framework is called Interconnected Multi-Tiered Systems of Supports. Now, when I show you the pyramid, you'll probably recognize that if you've been around, but essentially what it is it's a triage kind of framework that provides levels of supports based upon levels of need. Because we know that when children come to school, they come to school having been affected by factors that are beyond school as well as those factors that are within school. And if you're going to do anything meaningful with the child, you also have to involve the parents. And you have to get them connected as well. So how do you wrap a framework for the structures of supports in such a way that it can meet all of those needs together? Well, the big idea was there's this framework that's out there. It's already sufficiently known in schools that you can transplant community involvement into that framework so that all students can be served. And it looks like this. The pyramid approach rests its greatest effort on that of prevention, which is across the board. Every child gets the preventative effort. And when we talk about prevention in a positive behavior intervention and supports kind of framework, we're talking about 3 positively stated rules, like be responsible, be safe, and then you let everybody know what that looks like, and you teach it specifically in every context. What does that look like in the classroom, in the hallway, in the lunchroom? What does be responsible look like in the bathroom? And the actions are actually stated in positive terms. It's replaced the old rules like no hats, no gum, that kind of thing, no running. It's replaced all of the no's with positively stated expectations. I love the one that I went into, the elementary school, in the bathroom. It said, aim well. What a positive affirmation of what to do as opposed to what not to do, right? And if kids get that, and that's what responsibility looks like in the restroom, you see, and you train that for every context within the school, every teacher uses that. It's posted everywhere, so what? So we've created a culture of positive expectation. That's true for everybody. Now, that's going to address about 80% of the problems that you have on a school site. There's going to be 15% of the kids that don't get it just from that. They need a higher level of supports. What does support look like for that population of kids that need more help? Well, this won't be a surprise to you. I'm in an audience of, primarily mental health providers here. It is not going to be any surprise to you to know that the effectiveness of the relationship between the therapist and the client is as powerful, more powerful than any modality that you choose to use. Does that surprise anybody? Do you know that the effect size of the relationship within a mental health context is 0.72? What does that mean for you non-statisticians? It means that the child would do 50% better when he has a positive relationship with his therapist than if he doesn't. Okay, everybody's saying, duh. Did you know that exactly the same thing is true in the education context? The effect size there is exactly the same, 0.76, which means that children who have a strong relationship with their teachers do better academically. Does that surprise us that relationships are our common root? So how do you provide more intensive services? You connect that child with an adult in such a way that they build a stronger relationship, and now there's accountability. We have what we call check-in, check-out, where the student comes in the morning, checks in with the adult. How are you doing today? Glad to see you. And the child checks out with that same adult at the end of the day. How did today go? How can we support you? See, those things that work, we say all ships will rise and fall with the same tide. Good teaching is good teaching. Good therapy is good therapy. You can provide it within any context. So the core features of an interconnected multi-tiered system, it looks like this. We're going to put a lot of investment in prevention. We're going to add to that these universal academic, behavioral, and social emotional screening as well as supports. And if the child isn't getting it, we're going to intervene early, and we're going to provide more intensive supports at that level of need. It's going to be based upon this multi-tiered approach so that you can triage the use of your resources. That will use frequent progress monitoring to see how kids are doing, and then based upon the data that you collected, then we can adjust what types of services the child needs within that context. And finally, it's always, always, always using evidence-based interventions. When we talk about evidence-based interventions, education has them, mental health has them, but they don't do any good if you're not providing them, right? And we have children that fail at that universal level. Oh, they just don't seem to be getting it. And then you walk into the classroom and you're looking around the classroom and you're asking yourself, where are your 3 positively stated rules? Because on the boards it says no chewing gum. See, they weren't implementing that beginning level with integrity. So does the child really need more intensive services? Or do I need to get that teacher on board in implementing that prevention layer of service? See, that's where we use those evidence-based interventions that are then implemented with fidelity. All of this is based around a framework that is designed to ensure that we have positive outcomes. So we have supports for social competence and academic achievement and safety. We're looking at the whole child, the academic, the behavioral, the social, emotional. We have practices in place that children understand what the expectations are at every environment in the school. We have supports in place to support those adults who have the responsibility for providing these services to kids. And then we have decision-making processes that are based on the evidence so we can adjust and adjust quickly to meet the needs of children before they fail any further. In our organization, we have a mission statement. That mission statement is the relentless pursuit of whatever works in the life of a child. Because somebody at some point in that child's life needs to say, I don't care where the funding is, I don't care what the agency is, I'm going to address whatever that child's need is, and I'm going to keep at it until we finally accomplish the goal. They need somebody on the child's side. If we can all take forward that kind of point of view, you can imagine how powerful our structures become. I'm not here to tell you that education has the answer, and I'm not here to tell you that our model of service will work everywhere and for everybody. But I can tell you that that mission statement, that will work for everybody, because if we hold true to keeping the kid in the center, then we can go back to what General George Marshall said, who's the person who was primarily responsible for the reconstruction of Europe following World War II. General George Marshall said, there is no limit to the good that you can do if you don't care who gets the credit. I don't care who gets the credit. I just want that child to be safe. Now, Ken has done some amazing work in this regard, because he has been able to cobble together the three elements of the whole child, the social emotional, the behavioral, the academic, and has put it into place in a model that is widely embraced by some of the largest school districts in California. So Ken, I'm going to let you explain how you work that magic.
So the first question as I step down from here is, which one of these speakers has attention deficit disorder? And it's the one that can't stand up there, okay? So is this okay? Can you all hear me? And I want to begin, speaking of attention deficit disorder, and tell you my son's favorite joke, but we have to do it as call and response. So in this case, I'm Eli, I'm the kid, and you all are the dad. Okay, so Eli comes home and he says, Dad, how many kids in my school do you think have attention deficit disorder? And you say, want to ride bikes? There you go. Eli's a great sounding board. I come home and I say, do you think this is a good intervention? And he uses words like sucks, right? So my wife did a paper way back when we were children in the 1980s. And the paper was on something she called opportunistic planning. And what she said in the paper was that the way you think change occurs is not the way change occurs. That change occurs when three elements come together. When political will comes together with funding that comes together with a crisis. And that's when you see big change. If you have political will but no funding, right, nothing happens. If you have funding and political will but no crisis, it might happen. We'll just all be gone before it does, because the process takes over and it takes years. But when you have a crisis and political will and funding, different things can happen. And that's what happened that allowed us to do a different kind of model. So the problem we were looking at, the problem we were trying to solve, was the fact that in a lot of the schools we were working, we were the mental health provider, right? And how many of you have school-based mental health providers, right? Or do that service? So we were the mental health provider. In most cases, the first thing we did was we tried to find an office, right? Because that's where the mental health services occurred, was in an office. And usually that was the book room, right? Because there usually wasn't a space for that. And then we tried to find time to do pull-out mental health, right? Because we were doing pull-out mental health, individual therapy, and sometimes family therapy if we were really, really lucky. And then we started talking with our school partners, and it was really clear that that was not what they wanted or needed and that it wasn't really working. It was helpful for the kids, but it wasn't really what they needed. What they wanted was an integration of mental health into their schools. That put us into their classrooms, right? That put us in a much more integrated way, working and training their teachers, doing individual plans with their kids. And then what we found out was that we would do a plan, and the teacher would do a plan, and then the resource specialist would do a plan. And we started talking about how do we integrate these things. And the other thing that we found, and this is probably the most important thing, was that there were schools where it didn't really matter what we did, because the school climate and the school culture was such that we were just putting out fires. Have any of you had that experience? Where you're in a school where you cannot get ahead of it. It is one crisis after another, right? And you can't get ahead of it. And we found that in big, big ways. So we started talking about what are the circumstances that would allow us to change and allow us to change that. And we were in a funding context, one of the key elements, that might allow that change, because we had just, 3632 had just transformed to 114. Did that create a little bit of a crisis in some of your schools? I mean, people were really, especially the rapidity with which that happened. And the other thing is, all of that money wasn't quite committed or spent yet. So we had the transformation to 114. And then we got local control funding formula on top of that. And how many of you are familiar with local control funding formula? See, less so. This is the biggest change in education that's occurred in California in any of your lifetimes in terms of education funding. And yet it hasn't fully penetrated into the mental health world. What local control funding formula does is it says, if you have foster kids in your school, if you have English language learners, if you have kids who are on free and reduced lunch and who live in communities that are impacted by poverty, we're going to give you more money. Because before that, nobody knew that it took more money to work with kids that were living in communities that were highly impacted. It took us a long time, and it took Jerry Brown being governor, frankly, to get that moved, to get local control funding formula moved. So now you have a realignment to the local district along with responsibility for special ed and mental health services. And on top of that, we still have some expansion in Mental Health Services Act funding, and we still have EPSDT. So you have all these factors that are coming together, and that allowed at least the possibility for a discussion of a fully integrated service system. And when I say integrated service system, I'm talking about all the way across school climate, school culture, mental health provision, and special education, and that's the key difference, and that's the hardest nut to crack. Because let me tell you, special ed people are very serious about special education. There is a mandate for special education. There are qualifying conditions. If you do not meet those qualifying conditions, you do not get special education. How many of you have been to an IEP? Let's have an auction. What's the most people that were at an IEP? Somebody just call out. Anybody more than 10? More than 10? More than 15? I got 15. Do I hear 20? I got 15. Do I hear 20? Anybody 20? You got 20? You've been to one with 20? At the presentation we did the other day, we had somebody that was at an IEP with 19 people. Of those 19 people, at least 14 of them were professionals. Their all-in pay rates for those professionals are at least $70 an hour when you include all the expenses associated with them, their administrative support and everything else. You do the math. That is one expensive IEP. Right? But that's nothing, because how much time did each of those professionals spend preparing for that IEP to make sure that that kid was qualified for special education? Oh, dear God, right? When we look at, there was an article in the newspaper when I started, this goes all the way back to 1985, Oakland Unified School District, my apologies, I love Oakland, I live in Oakland. Oakland Unified School District made the papers because one year they spent more on legal than they spent on services. They spent more on legal than they spent on services, right? And it's not, I don't want to put blame about that when you have a federal compliance system, when you have Office of Civil Rights complaints, when you have layers of compliance responsibility, you better make sure that you comply with the law and that you spend your special ed dollars correctly. So it's not an easy problem, but that service denial system is really, really costly, and it is unnecessary. I want to submit to you that it's unnecessary. Okay? So if you take that service denial system and turn it into a service acceptance system, and you say, I want to create an integrated system redirecting those funds at the earliest, actually not the earliest possible, at the highest impact intervention opportunity, do you get better outcomes? Most of us know kids with learning disabilities that do not have an emotional overlay. Most of us know kids that have an emotional overlay that don't have learning disabilities. But there's also an enormous group, and I want you to picture this. I want you to be the kid in the classroom where the teacher hands out an assignment. This still happens in classrooms all over the place every day. Hands out an assignment and says, okay, you guys, here's an assignment. Now, when you finish, everybody, you get to go to free time. And you get to be the kid that sits in the chair and watches one by one as every other kid puts his assignment on the teacher's desk and goes to free time. Now, even without an emotional overlay, I don't know many adults whose frustration wouldn't go off the roof. And that's when you start to see the interaction between that emotional overlay, and that's why you have to see this integration of funding. And the integration of funding is designed so that you have a smooth delivery of service across everything from that beginning point of school climate and school culture all the way to high-end services. So, oh shoot, I forgot though. I'm not supposed to say school climate and school culture in this room. I forget which audience I'm talking to. Because my God, if I ever ask you guys to spend money, mental health directors, how many of you fund school climate and school culture? Now, if I said stigma reduction, how many of you would fund that? Right? Stigma reduction you would fund. If I said aggression, ART, aggression replacement therapy, right? Evidence-based practice, how many of you would fund that? How many of you do fund aggression replacement therapy? It's pretty well evidenced practice, right? But if I integrate that into a school climate, school culture curriculum, which is the greatest bargain in mental health, school climate, school culture is the greatest bargain in mental health, most of you don't want to fund it. So when I talk to school district, I talk about school climate, school culture. When I talk to you, I talk about ART and all the things that you can integrate. It doesn't matter. I'll take the money wherever I can get it, right? But about $30,000 a year for a school of 500 kids gets you a fully integrated school climate, school culture curriculum. So I'm going to skip this. So these integrated funding streams then come in to support a multi-tiered framework. And at the base of that framework, the most fundamental base is going to be that school climate, school culture, but there's also going to be a series of universal interventions that occur for the whole school, right? And then and each funding stream is going to come to bear at a different level. Primarily, we're going to use school district general education dollars, and this is why LCFF is important, to fund school climate, school culture. Primarily, we're going to use those dollars for that. So we're going to ask for a general education contribution. Anything above that, all the individualized or more individualized or small group interventions, we're going to use a combination of mental health and or special education dollars. And now you can see how these things build out into a three-tiered system. So if you have a very powerful school climate, school culture, and a very powerful series of tier 1 interventions, you really will impact 80% of the kids that won't need additional intervention. You really will. And I'm talking, now, we're not talking about cream puff schools. I'm talking about schools that are 95% free and reduced lunches in some of the most troubled neighborhoods in Oakland, is where we've piloted this project, okay? Even with the best universal interventions, you'll still have 15% of kids that will need additional intervention. And those kids will typically have some combination of mental health, AB 114, EPSDT, or Mental Health Services Act intervention. And you will have your high-end kids. And here's kind of the problem. Oh, I'm sorry. Now, this is delivered through a coordination of services team. How many of you have in some of your school-based programs people who are there to coordinate services on a campus? Please. A lot of folks know this. Nancy's going, I do! Okay. So I'll pick on you, Nancy. So coordination of services can range from great to useless. It can range from great to useless depending on its implementation. So Nancy's, of course, are great because she's my funder. We've seen cost teams that are actually destructive. Here is the problem, and it's the problem with that pyramid before. How's my time? Okay. Here's the problem. If the coordination of services team does not have at their disposal the resources to deploy to intervene immediately afterwards, people will become frustrated. And it's also the problem with this tiered intervention. Let me tell you, has anybody had a failed tiered intervention in schools? A failed PBIS implementation where people basically just didn't do it? Okay, I'd like to thank you all for being so candid. I have seen failed implementations. Here's how they work. The PBIS people come in and they say, we're going to train you guys how to do this stuff and it's going to be great. Principal, you're going to implement the school climate, school culture curriculum. All you have to do, it's only going to take you about 4 hours a week to really do this well. Teachers, we're going to identify what kids need, primary intervention and secondary intervention, and how you can do it. We'll keep working with the high-end kids, okay? Okay, what's wrong with that picture? Anybody have a teacher in your family? You do? How many hours a week does he or she work?
She works in a Title I school in Hawaii, so she works way beyond the school hours.
50 hours a week? 60? Anybody have a principal in your family? I know a lot of principals. Nobody has a principal in your family? Yeah, you do. How many hours a week do they work? Never stops working. So just add 4 hours a week to your implementation. Just 4 hours a week. It'll revolutionize your school. You cannot do this without the resources. If you try to do it, what'll happen, interestingly enough, is they'll try to do it. Because these are really good people. For the most part, these are just like us. They are they are mission-driven and committed. They will try to do it. They will eventually get frustrated, and then they will get mad at you for asking them to do something that can't be done, right? And that's the problem with tiered interventions and with cost teams, with coordination of services teams that aren't resourced. So here's how our cost team works. You're not going to believe this, but it's really true. We make a promise to teachers, parents, or kids that come to the cost team. It happens once a week, and there's open office hours in other times for more urgent needs. If you bring a kid that needs help, we will make a plan with you for what that kid needs, and we will implement that plan within 48 hours. We will implement that plan within 48 hours, and then we'll come back a week later to make sure you believe we have implemented that plan. And then we'll come back every 4 weeks to see if it's still necessary and or if it's working. How on earth could we afford to do that? Well, we've taken all of the money that was in special education for that school and all of the money that was in mental health in that school and some regular education resources, and we have redeployed them to be implemented through that cost team. So there is no central special education in this school. And oh, actually, I already did this. Cost is only successful when it's embedded in overall school climate, school culture, when the school climate and school culture support students' access to it, and when the culture celebrates and upholds inclusion. That's the key. So, and we have not had a single child in the systems where we've implemented, actually that's not true, we now have had one child go to non-public school or segregated site programs. And that's the problem, that's what you have to do to fund this. So typically, in most urban districts, and especially in high poverty neighborhoods, about 81% of the funding goes to segregated site interventions. Either special day classes, non-public school, day treatment program, and that costly IEP process. All the costs that go into then supporting it, right? 81%. So if you're directing the lion's share of that funding back into the classroom, and this is, when we did this slide, it was 100%. We're now at 99.6% inclusion. You have a whole lot more funds available. What's the problem with that? I got one special educator here. Any other special educators here? Special ed's centralized in almost every district in the state. It's centralized. So you're going to centralize special ed and you're saying, you know all those people you have? We want to redeploy them into classrooms. So they're actually working in classrooms all the time. And it's really hard to do because they have demands all over the place, right? So just one case example, then we'll move on. Joseph, we'll call him Joseph. This project started with an initial referral for a non-public school. And I love the way my staff describe him. He is a bright, articulate, they have gotten the positively based, strength-based description to a science. So they will always start with, Joseph is a bright, articulate, and persuasive 11-year-old boy. He's persuasive because he will beat you to death. Joseph was very aggressive and assaultive, and had on numerous occasions assaulted kids and staff in class. And then his favorite thing to do was to refuse to leave the classroom while he acted out in very dramatic ways. So this school called us for a non-public school. We run on segregated site non-public schools with day treatment, with mental health component. Joseph's behavior problems were disrupting the whole school, and this school had very much an inclusion orientation. So when the principal called to make this referral, and it just happened to be a friend, she called me and she said, nobody in the school wants to lose this kid, but we don't know what to do. Man, when you hear those sentences, you've hit gold, right? Because to make this work, you have to want to keep the kids. And so we went through, what are you going to spend if you go to non-public school with this child? This child was in a charter school, so it was an easier discussion. And we went through what the cost would be in non-public school, what the cost of the mental health intervention. And we said, well, let's take those resources and move them into your school. And even if we have to one-to-one him in a separate site, we can do it for about the same amount. Might cost a little bit more for a while. Joseph began integrating back into the classroom after 60 days. Now, those of you who have used non-public school segregated site programs, how often do kids go for 60 days? Ever? Never. Really never, right? He was fully integrated, all but actually 4 out of 5 periods. He never went back for the 5th period. We did that solo. Math frustration tolerance was an enormous trigger. We are still, I don't know how long we've had Joseph now, but we're still doing math one-to-one with him, right? Outside the classroom, right? But 4 out of 5 periods a day, he's back in the class. We did intensive TBS with him. We did intensive case management with his family, where he was really struggling, right? And we kept him on the site. That's actually what led, ultimately, to us doing this full integration in the school. So when you take all of the resources that are going into service denial systems, into systems that intervene way too late, and you focus them with the teachers having a tremendous amount of control and responsibility and a really good team on the school site, you can actually accomplish this within existing funding streams. And now I will introduce my friend Leslie, who will tell you about implementations in the context of health clinics.
Okay. I wanted to start with a slide that Ken showed earlier about the continuum and talk to you a little bit about the top right part of the continuum. And when I was invited to speak today, I thought that there's a sort of amusing set of questions or comments that I often hear. For those people who are doing county mental health services, EPSDT or other county mental health, I continue to hear, oh, it would be so great to be an FQHC. They can do everything that we can't do. They have so many advantages. And for the people in the FQHCs, they say, boy, there's so much that they can do in specialty mental health that we can't do. So we thought that before we open this up to general conversation with the larger group, that it might be helpful to talk a little bit about understanding what the FQHCs can and can't do, and how that compares to what the county mental health systems can and can't do. And I'm going to use EPSDT because this is a children's presentation, but really it's a substitute for county mental health because the same services that are funded for children under EPSDT are the same services that are funded for the adult population. For those who are not familiar with where I work for a federally qualified health center called La Clínica de la Raza. We are in Alameda County, Contra Costa County, and Solano. We have 32 sites in the 3 counties. 17 of them are primary care sites, of which I think 8 or 9 are school-based health centers. And we also have 2 specialty mental health standalone clinics that are not operating as FQHCs. They're operating as county contracted mental health organizations. And my role is to oversee behavioral health. I'm actually not the clinical director at La Clínica, I'm the behavioral health director. And we have 17 primary care clinics where we have integrated behavioral health, and we have the 2 specialty mental health programs. So at the end of my probably about 15 minutes, my hope is that you will have clarity on what an FQHC is, what are the differences in services between the FQHC and the county mental health services, what the differences are in the staffing, the population that gets served, the limitations of the FQHCs, as well as how that compares to the limitations of the county mental health or EPSDT programs. And then to have a little conversation about if you're at a school and you have a choice, which one you might decide to pursue first or both at the same time. And then my hope is after we would then open this up to more conversation about how this links into issues of school climate, which is not the specific focus of either an EPSDT or an FQHC type program. Okay, an FQHC is a federally qualified health center. It comes out of Section 330 in the Public Health Code. And basically, they are federally recognized sites that are part of the safety net of the health system in the United States. And we heard a little earlier somebody talking about the poor Medi-Cal rates and how it's really hard for their agency to be burdened by Medi-Cal. It's very interesting because Medi-Cal is our best payer, because our comparison is between Medi-Cal and no payment. And you know, people say, well, healthcare reform, isn't everybody insured? It depends which FQHC. So there are FQHCs in which 90% of their uninsured population has become insured. At La Clínica, 78% of our uninsured population continues to be uninsured. So depending which uninsured population you're serving, there's a pretty wide range of how many people have converted onto Medi-Cal. There is a set of required services. Those include things like you can't be an FQHC if you're not providing primary care services. You have to do health education and those types of things which we don't talk about or know or have much familiarity with in the carved out system. The population served, unlike county mental health, there is no authorization process. Whoever comes to the door and requests services, whether they have the money to pay or insurance to pay or not, you have an obligation to serve them. So whether the FQHCs are going to get reimbursed for the service or not, there is a sliding scale, and nobody can be turned away for a lack of ability to pay. There is a very specific set of providers, and as we go through this, you'll see this is one of the real determining factors in thinking about one of the major differences between the FQHCs and the county mental health programs. And as you heard earlier, people talking about the workforce shortages. Those are shortages in mental health in general. When you add the FQHC requirements on top of that, you will see, as we go into the next few slides, that it gets 10 times worse. There's also, with the FQHCs, a way that rates are set. And that is, after the first full year of implementation, they take the total cost of that program. So if your program costs $1 million, then they look at the total number of eligible services. That is only eligible services by eligible providers. So if you have $1 million program and you had 10,000 eligible services, they take $1 million, divide it by 10,000, and your FQHC rate is $100. That means that any amount of services that's provided in a single day, you will get $100 for. FQHC rates range greatly. I have heard of FQHC rates that are about 110, and I've heard of some that go up to 200 to 300. At La Clínica, we have not that big a range. But in terms of, people often ask me about the FQBHCs, and as we go through it and you see the eligible providers, one of the questions is, why aren't we an FQHC in our carved out mental health program? And that is because our rate would probably be about $5,000 per encounter. And that's because we have so few eligible services. An eligible service is going to have to meet a very specific set of criteria, and only by a very specific set of providers, not all of our behavioral health providers. The other thing about FQHCs is that it is quite a process to get them certified. The county mental health programs, you have somebody from county mental health that comes out and can certify your site. That process can take a few weeks. And FQHC is a much more complicated process. You have to establish primary care, you have to have sinks, you have to have a wet sink for every dry sink, you have to have certain kinds of waiting room, you have to have certain air vents coming in and out. So you can't really go to school and just find the janitor's closet gets converted into an office to become an FQHC counseling office. You do need a significant amount of space. And it's not something that can transfer from one place to another. Once it's set and they know which walls it is, it can't just move from one place to another. Unlike a county mental health program where really they're certifying the school and your office may move to different places. Okay, so what services are funded in each? And I thought it might be helpful just to do a side-by-side comparison. And this is where you start to see that the FQHCs look at county mental health and go, wow, a lot more is funded over there than with us. Both of these settings, assessment therapy, crisis, and psychological testing, as well as medication visits, those are both included services. What's different about them, even though it's the same service, is how they're billed. If you did psychological testing and it took you 4 hours of testing on a day, and maybe you started writing it up and it was 5 hours, that gets billed as 1 times your rate. So if your rate is $150, you will get $150 for it. If your therapy session took a half hour, you would get that same $150. So in thinking about the county mental health services and about time, it's really important to understand that the FQHCs get paid once for any number of services they provide on that day. It doesn't include time, so it doesn't matter how long it takes you to write it up. It doesn't matter if you traveled somewhere. None of that matters. And a service is a service, and it gets paid exactly the same as long as it's by an eligible provider. So you'll notice that the services that the FQHCs do not get paid for are rehab, collateral. All those conversations with teachers would not be reimbursed in an FQHC. The rehab of helping kids with classroom coaching, how to stay in their chair, that kind of skills development, all those activities of daily living are not reimbursed by an FQHC. There is no such thing as brokerage or case management, and there is no such thing as treatment planning. So when we think about our specialty mental health programs, we actually spend a lot of time doing this kind of thing. And then when you add the amount of time for documentation on it, you can see why the FQHCs say, they've got some good deal over there. Okay, other comparisons. In EPSDT, we have a much wider range of where those services can take place. And again, EPSDT is substitutable for all county mental health. The service can be in person, it can be over the phone, it can be in the field, in the community, it could be in the streets, it could be in another office somewhere. In an FQHC, only face-to-face visits are potentially eligible. In the EPSDT, you can also go to wherever the client is, an important part of providing the type of services for the clients who meet the specialty mental health criteria. And in an FQHC, they must be in the 4 walls of the clinic. That means that if your clinic is a certain space and you get certified in that space, if you were to meet a child in the principal's office and do an intervention, that is not an FQHC billable or eligible visit. So it's just really important when we think about school climate and the kind of work we might want to do in the classrooms. All work in the classrooms would get excluded from being able to be billed by an FQHC. The other, and I think that one of the most significant things is the eligible providers. And as you were hearing the comments before about needing input for OSHPD and how they do their planning, and that there's only, X number of social workers in the state and X number of nurses. In an FQHC, you cannot get reimbursed for any services by students, so none of the MSW interns, the postdocs, none of them. You can't get reimbursed for any services by an ASW, by an MFTI, or by an MFT. So the only people you can get reimbursed for are LCSWs, PhDs, psych NPs, and psychiatrists. Okay? So if you think about your hiring challenges now, you think about most of us need people with different languages. How many Spanish-speaking LCSWs and PhDs are there in the state of California? So you can see that while it's a nice idea, one of the challenges the FQHCs have is if they hire somebody before they're licensed, they will not get reimbursement for them until the point that they are licensed. Now there's been a slight change, which we're really appreciative of, which goes back to January that just passed. And that is through the managed care Medi-Cal plans. While we can't get our FQHC rate, we can, for the counties that are allowing it, at least get the health plan reimbursement rate. But as we think about if we're going to start going into schools, the type of workforce we're going to need, there is no way we're going to have enough LCSWs and PhDs to staff the kinds of programs that Ron and Ken have been talking about. The other thing is the issue of included and excluded diagnoses. And in this area, the FQHCs have more flexibility than the county mental health programs. The county mental health programs have a list of included diagnoses. In the FQHCs, the diagnoses can be a health diagnosis, so a child who has asthma, whose stress is triggering their asthma, they can code, it's called a health and behavior code, but they can code asthma as the diagnosis and they can do a behavioral intervention for the condition of asthma. They can also bill for all mental health and substance use diagnoses, okay? There still must be a diagnosis. Just as in county mental health, you can't provide a service, you can't get it into that INSA system if you don't have a diagnosis. It's the same, no bill can go out with an FQHC or through an FQHC that doesn't have a diagnosis on it. Okay. EPSDT, this is my opinion, is much more client population focused. In other words, an EPSDT provider on a campus or at a school generally is not serving all Medi-Cal EPSDT eligible youth in the school. The FQHC focus is more of a population focus, and the responsibility that FQHCs have is really to serve the whole population, whether the FQHC is going to get funded or reimbursed for it or not. There isn't anyone that gets turned away. The EPSDT programs are very focused on people who are full scope Medi-Cal, and particularly people who have already qualified for full scope Medi-Cal. Most EPSDT programs are a little hesitant to take somebody who has hasn't yet gotten onto Medi-Cal, because there's always a concern about will they actually be eligible? Will I have done a lot of services and then not be able to recoup it? The FQHCs, though, have enrollment, most of them have enrollment specialists, and those enrollment specialists are right there at the sites and helping people to enroll in the different program. The FQHCs have Medi-Cal as one of the programs, but they also work with a lot of the private companies to try to credential, whether it's through Beacon or Anthem or HealthNet or Value Options. There's a lot more credentialing that happens because, again, they can't turn somebody away whether they're going to get reimbursed or not. The other kind of new thing that I think we're all struggling a little bit with is how we're defining which population is considered mild, moderate, and severe. I think the very severe is obvious, and I think the very mild is obvious. But it's really unclear what's going to happen with the people that are severe, whose condition is severe, and we all recognize that it is the responsibility of county mental health, but that they might choose to get served in the federally qualified health center. And I think the state's position has been, well, just contract with the county. And I don't think many FQHCs in a primary care clinic can take on the level of paperwork that is required to actually contract through the county. And that's just, the reality is to do an assessment in primary care, you have a back and front of one page to do an assessment and you're done. The process in a specialty mental health is a 6-page long assessment. It takes a lot to get them open on the computer, to get them registered and open encounters and all of that. And I don't see, unless federally qualified health centers are going to have a very large behavioral health program, that they're going to be able or willing to take on that kind of contracting process. The other thing that people say is, well, don't they have to? The state of California is pretty famous for making a state decision, such as a few years ago, the state decided, Governor Jerry Brown, I think it was, that adult Denti-Cal just will no longer be the state's responsibility. Well, that was nice and good for the state. The problem is that the state got sued, and it is a federal benefit. It's already in the scope of the federally qualified health center. So if it was already in your scope, the state couldn't just say, we're no longer going to pay for it. And I think that that's a question mark out there right now, is for the federally qualified health centers who are staffed and their programs are designed to serve people with serious mental illness, whether the state is going to be able to just say, we just will not pay for it, or whether that will go the same way that has happened with various other services, including nutrition services and dental services, where the state won't pay, then there's a lawsuit, and then the federally qualified health centers win. And that's because it's already in their federally approved scope of service. So if it's in your federally approved scope of service, the courts have pretty much held up over time that the state can't take away that which was already authorized by the federal government. So I say that only because it's still a big question mark as to how California is going to handle it. But I think that there's also some of the federally qualified health centers are interested to continue to do the services they have been doing. And some are very happy to refer people who are more severe to county mental health. It really just depends on which center. I've already done that. Look at that. It's a duplicate, huh? Okay. Okay. So I had mentioned to you that the EPSDT programs, as we know, are very focused on the full scope Medi-Cal. One of the advantages of the FQHCs is that they have a wider range of Medi-Cal that they get reimbursed for. I shouldn't say they, we get reimbursed for. We do get reimbursed for full scope Medi-Cal. We bill the state, and then the difference between what the state pays and what the federally approved rate is what the federal government pays in a cost settlement at the end of the year. So it makes the federally qualified health centers whole for every eligible encounter. And remember, eligible encounter means none of the phone stuff, none of the stuff that's outside of the clinic, but in the clinic, face-to-face, with LCSWs and PhDs only, okay? But we have some additional types of Medi-Cal in the FQHCs that we do get paid for. One is the gateway Medi-Cal. We're a little less gun-shy about using gateway Medi-Cal. EPSDT does reimburse for gateway Medi-Cal. It is a presumptive eligibility, so if a child is not on Medi-Cal, a gateway application can be submitted, and for the rest of that month, as well as the full 30 days of the month after, the child's reimbursement is as though they are full scope Medi-Cal. So why are specialty mental health providers a little hesitant about that? One is they don't have control of when those applications go in, so they're not always knowledgeable about whether there's 31 days of service or 60 days of service available. And the other is that in starting a specialty mental health service, we generally are not going to drop a client as soon as if they are not eligible for EPSDT. And so there's a lot of hesitance to start those services. There are some additional kinds of Medi-Cal that, and other services that the FQHCs get paid for. You've probably heard the terminology of minor consent or sensitive services, and there are two in particular that are used for youth that are 12 and older, so from 12 to 21. There is a code which is 7P, and this is a sensitive services mental health service. It is a service that the minor can consent to themselves, but it is quite restrictive. The youth must be determined to be in serious danger of harm, physical or emotional harm to themselves. So it's not just any kid who has depression or anxiety or trauma. There has to be a letter that goes from the behavioral health clinician. There's an on-site application they can do, a letter that goes with it that determines that the youth is in serious danger. The second is one called 7M, and this is also a sensitive services Medi-Cal, but this is not for mental health services. This is based on other conditions. So this includes counseling related to sexually transmitted diseases, related to sexual assault, related to drug and alcohol abuse, related to family planning, pregnancy prevention, and that's one that is not included in in EPSDT services. There are also contracts that most FQHCs have with various health plans that are in their own counties. There's Family Pact, which is a family planning service. Some will take victims of crime. And then some counties have a CMSP type program. In different counties it has a different name. And that is where the county is using county general funds to serve the uninsured population. Why do they do it? Because if they don't put some money into it, they're going to end up having to cover the hospital costs. So each county will make its own determination as to how much of general fund money it's willing to put towards primary care services to try to prevent more costly services. So the question comes up, what about the uninsured? Just as EPSDT does not pay for the uninsured, federally qualified health centers do not get reimbursement. There is no FQHC reimbursement for uninsured youth or adults. Okay. Okay, so I thought I'd do a little bit of a side-by-side before I wrap up about some of the things I sometimes think about in terms of coming onto a school campus or trying to meet a population's need. The first is in an EPSDT program, we generally think about caseloads. Can an EPSDT provider have 75 kids that they're seeing for therapy? Could they possibly have 75 charts open? Could they have 50 charts open? Could they have 35? I would guess that there's not an EPSDT provider in the room that has clinicians that even have 30 cases open. So why is that? It has to do with the amount of documentation that's required, right? So what I've seen when I ask people in different states and different agencies, what is a caseload for an EPSDT provider? The answer is generally, given the amount of paperwork there is, and given what it takes to get the case open, that could be anywhere from about 15 to, at most, I've seen 25. So when we're looking at the number of clinicians that would be needed to serve the needs of a school, it's a pretty big number, unless we use EPSDT to only serve those who are really at the highest end. Okay? In an FQHC, there is no such thing as a caseload. There is, for the behavioral health clinicians that we hire in other FQHCs, there is no such thing as being full. There is no such thing as not having space. The goal is to serve the population. So how do we do that? Well, one is it is not as labor intensive in terms of paperwork to get a case opened. But the other is that there is not a sacred 50-minute-hour kind of psychotherapy model. And kids or adults are not necessarily seen on a weekly basis. So that's how it's done. Follow-up appointments are not always the next week, but when you have the whole population, you have to do your own triaging. One of the other differences that the EPSDT programs, as I mentioned a little earlier, because County Mental Health is able to certify them, what we have experienced from the 3 counties we're in is all 3 of the counties are quite efficient in having certifying staff come out and getting those reporting units open. So it really can happen in a fairly quick basis. The licensure to try to open up a new FQHC site is not a 1 or 2 month process. So that's one of the considerations when you're thinking for a school about which might be better served. The other thing with EPSDT is the startup cost is pretty low, right? You need a chair, you need a desk, and you need a computer. And maybe you even need some play therapy toys or something like that. In an FQHC, remember this is a primary care clinic, so you have to meet all of the requirements for a primary care clinic. So it's really quite expensive. We have 32 sites. We have not opened any sites if we didn't have a specific HRSA grant or specific funding to be able to do it, because the construction costs to be able to establish a primary care clinic is not something you can just recoup in basic operating revenues. The other thing I thought I'd talk a little bit about is just sustainability in terms of, to sustain an EPSDT program at a school, you need to have, if a caseload to be able to bill enough to sustain 1 clinician is 25 clients, you only need to have 25 kids on full scope Medi-Cal who have an included diagnosis in the school. In an FQHC, you've got to have a large enough school. There is not a small caseload, so the school has to be large enough, and the percentage of the youth that are on the free lunch, which is not a perfect proxy, but at least an indicator of who might be on Medi-Cal, because remember, all the undocumented kids are also on the free lunch, but they're not on Medi-Cal. And so really, it's very hard to think about establishing a federally qualified health center in a school that's a very small school. It's also extremely difficult to consider doing that in a school that doesn't have a high Medi-Cal population. So, which might be better for serving a school? I don't think there's a perfect answer. Both of them have advantages and disadvantages. It is crucial that either the EPSDT or the FQHC are part of a cost team. I have seen EPSDT providers in their own wing or in their own part of the school that never really get integrated in the school. Is it good that they're there? It's good for those 25 kids that get served. It doesn't really help much in terms of school culture or social emotional health of the school. I've seen the same with FQHCs, where they're in another building or another part of the campus, or sometimes outside of the campus and located between 2 campuses. And again, if they're not really part of the school, I think you end up with some of the same challenges. The reality is that it's much more feasible right now if a school does not have either EPSDT or an FQHC. The one you could get up and going quicker, depending on your own county mental health director's choices, would be an EPSDT program. And I know that there's some concern, and we keep hearing, well, is EPSDT, do you really have a cap, do you not have a cap? It seems that there's still some concern, even though we've been told over and over that there is no cap, and if you go over, you will get reimbursed. I think that there are still some counties that are not yet convinced of that. But in terms of starting it up, it is not as easy to start up in an FQHC. So if you have a school with neither an FQHC nor an EPSDT program, and you want to get something going in a relatively short amount of time, the service that you can get it up and going a little bit quicker, or actually a lot quicker, is an EPSDT program. And the EPSDT services at the school, it is a wider range of available clinicians, which is really important when you need special languages. It's a much wider range of eligible services. As I went through those services before, it includes the brokerage and treatment planning, collateral, and all of that. But the other really important thing for a school is it allows flexibility in location. So where the FQHCs, the child must be brought or walk into the walls of the FQHC, that specific space. EPSDT is the option that would allow a clinician to actually do classroom observation, classroom coaching, working with the teacher in the classroom to assist that student. If there are crisis interventions, the EPSDT clinicians can go out to wherever on campus that crisis is happening. It's much more difficult for the FQHCs to do that. So, before I turn it back to the rest of our panel here for more conversations with you all, I was thinking a little bit about this issue of prevention. They put on the thing, use of FQHCs as in prevention. As I mentioned, for an FQHC to see somebody, there still has to be some kind of diagnosis. So what is it, given that it's easier to establish a county mental health program, especially a small program, like a single clinician at a school doesn't cost near what setting up a medical site costs? Why is it that it's so difficult to do prevention with EPSDT? And we always think of the FQHCs for prevention. Well, the FQHCs have that advantage of a much, much wider set of insurances that it can accept. But there's also a challenge with the EPSDT with prevention that I think is actually potentially solvable. And that is that it's hard for us to do prevention because of the issue of prevention tends to be short-term. It tends to be something you can do in a few sessions, and yet the paperwork for it is assessed the same way that a long-term client would be assessed. And so one of the sort of policy things that we might think about together is that if a youth has a case that gets open, is there a way in our system, not now, but maybe it could be, to provide a mental health service without having to diagnose them first? That would lead us to being able to do more prevention. And is there a way to not have the full set of criteria around all the elements that are needed in the assessment, to really only apply after somebody gets maybe to that 60-day point? I think right now the counties are look at these services all in the same way, and I think it's because the perception is that that's what the state is doing. We're not talking necessarily about can you do 60 days of assessment, because what we're talking about, can you actually do prevention, which is more than assessment. And so I think that's an area for us to think about from a policy standpoint is EPSDT, is there a way that a case can be opened that doesn't require in the system a diagnosis and it's not going to trigger a lot of red flags? But is there anything we can do to say that the paperwork that is required, and I know people know my mantra is paperwork, but that only kicks in at a certain time. If it does, if it kicks in at the 60-day mark as opposed to the day a case is open, the day you bill that assessment, it's assumed that you're going to have a full assessment, and that is that 6-page long assessment. I think it would free county mental health contract agencies and the county sites themselves to really look towards being able to use EPSDT in a more preventative way than we are able to do right now. Whether an FQHC ends up being the direction that you think would help a school or an environment or an EPSDT program, the important thing is that neither one deals with school climate. Neither one can really deal with the whole population. So as you were hearing from Ron and Ken, the answer to helping a whole school and dealing with that 80% as well as the 15 and 5% is not a standalone EPSDT program, and it's not a standalone FQHC. It really is an integration of these services and providers who really value a cost team, and that is where they get together and from the behind the scenes figure out the money and who's going to do what, because that's not a child's responsibility and that's not the parent's responsibility. So that when somebody gets identified as needing help, that all of the organizations that are on site can all look at what they can do and not what they can't do. Okay, thank you.
So are there any questions for the panel? So Marty has a question.
Unless you want to give me one. I think my question is to Leslie, but perhaps both Ron and Ken. One of your slides, Leslie said, which is better, EPSDT or FQ? I guess my question is, where do you see FQHCs fitting into that braided funding? And I'm talking about not only the funding, but the service, but let's talk about the funding. You've got, perhaps local control funding formula at the front end with school culture, school climate, Mental Health Service Act, maybe somewhere in the middle, and EPSDT at the high end, or might overlap in the middle as well. Where in that continuum can FQHCs best fit? Not either or, but best fit to be part of that continuum on a school campus?
I'd like to see an FQHCs being able to serve anyone who walks in the door, but also being able to see the youth before they get to the cost team, so that if a child is going to need some health services, the cost team would not necessarily know that if there hasn't been some kind of evaluation. I think that the question often is, what's the right flow? And I think somebody was talking earlier about the issue of flow. It seems to me that the flow that makes sense is to flow through the FQHC. If the child is assessed to need 2, 3, 4 visits, 1 visit, the FQHC can take care of that, and therefore we could use those EPSDT available slots or availability for the kids who need a higher level of intensity, who might need follow-up in the home, who might need follow-up in the classroom, who need maybe weekly or a more intense level of service. So if there's a school that has the advantage of being able to have both an EPSDT program and an FQHC, those together, again, are still only part of it because you still have the school culture piece. But in terms of how they work together, I see the FQHC being a good place to find out, are there other related health issues that are impacting them? And being able to assess, is this a short-term kind of counseling? Or is this condition or the child's situation one in which there's more involvement that's needed? And that to me is a great determining factor if a school is fortunate enough to have both, as to which ones might remain in the FQHC, somebody who needs a few visits versus somebody who needs a higher level of intensity.
So it's almost a contribution to universal screening.
Yeah.
It's a piece of that.
Mm-hmm.
Hi, I thought the three of you were absolutely terrific, so thank you for great presentations. My question's for Ron. I'm wondering, one of the areas of controversy for services driven by IEPs is work with families, where some of the family conflict and family issues don't necessarily directly impact the schools. How do you address that, and do you do home-based work with your EPSDT contract?
Yeah, we do. We see families as being an integral part of the success for the child. And of course, we know that you many times are thwarted by the family environment from doing the things that you need to do. So we engage with the child, we'll go into the home, we'll do homework. We have a TBS contract in addition to our school-age treatment. We do CIS as well. We have that contract with the county. And, let me just say that if we did not reside in San Bernardino County, where the agency folks there have been such wonderful partners with us, I just don't know that this would be possible. And part of those relationships that go back so many years that allowed for that trust to build between the Department of Behavioral Health and the education system has parlayed itself into just an increasing level of creativity about what can we do to fix this and then this and then this. So yes, we have those agency contracts now to be able to do that, but even before we had the TBS contract, we were still going into the home because it's the right thing to do.
Thank you.
Are there other questions for the panel? We have a question from Marv in the back.
So, in a lot of experience with school-based programs and the use of EPSDT, I know that the majority of programs that I know about that use EPSDT in school-based programs are not 50-minute, hour kind of programs, but are really engaged in doing whatever it takes to engage not just the kid in the school. I remember in my early days in Kern County when I was doing this, one of the things that we found is that as we got engaged in school-based programming, that the kid that was being called out as needing the intervention, when we did the home visit, oftentimes that child was the most functional member of his or her family. And the emphasis really needed to be on trying to find a way to engage with the family. So I guess my question for the panel is, in thinking about EPSDT and FQHC services, how are you thinking about the interventions on the substance abuse side that need to take place, both with the kids and then also with the families where that may be needful?
That's a great question.
Well, let me start then. We have great relationships with other community-based partners. You know, we have narrowed our focus so we only focus on the children. And when we go into home environments where the needs of the parents are the ones that really are first and foremost, we'll refer. And we'll bring in our other community-based partners to be able to work directly with the family. We may continue with a child because we have the child in the school setting, but we'll do that coordination among agencies in order to address that. We did have a substance use and abuse program that we offered. We do have some counselors who are trained and certified in that regard as well. But for the most part, the substance use issues wind up also being referred to other agencies because they just have more in-depth, they're deeper in terms of the resources that they can draw upon than we are in that regard.
In terms of our county mental health programs, if it's a co-occurring substance use and mental health disorder and mental health is primary, then we treat all in one in a dual diagnosis type of way. And in our FQHCs, we work on if substance use is an identified problem, we do motivational enhancement. And we've never had a client coming in, or I don't know of a client that had come in and was ready to go to treatment. There's quite a bit of work that needs to be done around really understanding the substance use and the impact it's having, and really working with somebody until they're ready to go to treatment. So we will work with people up until that point that they are interested in going to treatment, because there's no reason for us to refer if they are not motivated to go to treatment or don't see it to their advantage. So we see ourselves as, and our role in the FQHCs for us, as doing the motivational interviewing, doing things like the payoff matrix and that sort of thing, and really being the bridge to treatment. There are FQHCs, though, that in their scope of service, substance use treatment is part of their scope. So it is a required service, but FQHCs can either do the service or have an agreement on where we're going to refer. And so some of the FQHCs actually have in their scope that they do substance use treatment on site themselves, and others have it in their scope that the way that they address substance use disorders is through referring people to treatment. So we do up into what we call as treatment. We don't do residential, we don't have milieu, we don't have groups, but what we do is individual one-on-one motivational enhancement up to the point that somebody determines that they would like to consider treatment, and then we see it as our role to help bridge and link them to treatment.
Substance abuse is a good example. But in the fully integrated models, what happens is that we end up taking responsibility for all things outside of mainstream education in partnership with the school. And so just to give you, even though they're trained in it, there's not deep expertise in the child welfare system in most of the schools we work in. There's not deep expertise in the juvenile justice system. And so what will happen is if a child goes to juvenile hall, it's assumed that our team will then take over the management of making sure that that child gets integrated back. Same with making a CPS report. These are things that in the past would have taken hours and hours of a principal's time, partly because the principal's having to learn each system and intervention. And those interventions are second nature to us. So in the same way, if substance abuse treatment is required, we would not necessarily have that expertise, but it would certainly be our responsibility to bring that expertise to bear and then to case manage that.
Great. Are there other questions for the panelists? Okay, well, Leslie, Ken, and Ron, it's been a great presentation of the various ways that services are provided in schools to children and models that could be adopted. So thank you very much. Really a didactic presentation. Thank you.